So I want to talk about like best uses and best practices, but the way I want to ask it is, how have you guys messed it up, if you don't mind talking about that? Like, when have you seen it go wrong? And then we can take away, like, that way everyone can learn from, maybe it wasn't Dr. Siskin, maybe it was the fellow, maybe it was a
It's always the
partner.
fellow.
Yeah, it's always the fellow, right?
Right.
But, like, just things that like, if you could anticipate, like, what a new user of a liquid embolic, some of the learning curve they might have to go through.
All right, so let's imagine you're in a pseudoaneurysm. Has
Okay.
a little bit of size to it. Or better yet, let's say an off-label use in an endoleak, for example. So you picture yourself in a large space and you're trying to fill that space. We got fooled, and it's almost embarrassing to talk about because we got fooled in terms of reaching an endpoint that was a false endpoint. And if you just take probably 5 seconds to think about it, you'll realize what happened. The patient was laying down, right? And it is a liquid. So all the liquid was layering into the dependent portion of the space. But as it layered, it looked like we were filling the entire space when in fact we were only filling the dependent half of the space. So we thought that we had filled the space completely. It looked great. We were confident we were done. And when we scanned the patient a few days later, we literally saw contrast just flowing right over the liquid. And we were, needless to say, not happy with ourselves. And we went back in and completed the job. But what that taught me is simply to have a clue about the volume of space that you're trying to embolize. It doesn't have to be perfect. You just need to have some idea. And as you do more, you'll start to know that. You'll start to know that this vessel is typically zero 0.8 ml or this size pseudoaneurysm. For example, one of the benchmarks I use is that a 12 millimeter pseudoaneurysm is 1 ml of liquid. So it's just a benchmark that I know. So if I'm treating a 12 millimeter pseudoaneurysm and I only use half an ml, I know that something is wrong, that it's a false endpoint. And that's why I tend to at least give a little bit of thought to how much embolic I think I'm going to be using. Sometimes it requires me to break out my middle school geometry textbooks and look at a formula for a cylinder for a vessel or a sphere for an aneurysm. But once you do that, it's not as horrific as it sounds to do that. And so it's just nice to have an idea before you start.
Okay. Any other scenarios that you can think of? I mean, that's a fantastic one, and it's a fantastic rule of thumb, the 12 mLs per hold on, I've already
1
forgotten it.
ml for 12 millimeter pseudoaneurysm.
Yeah. Anything else you can think of?
Yeah, just be careful about the reflux, right? Just
Okay.
be very aware of it. And so I think there are times when it might reflux faster than you think. And a lot of that comes down to how quickly we're injecting it. So I think it really comes down to the basics of your technique. And if you're injecting it slow, and you're looking for reflux, you'll see it before it's a problem. I tend to like a scenario where I do these embolizations with the idea of controlled reflux in mind. So in other words, I'll go further into a vessel, and now when I see reflux into a more proximal vessel, that becomes my endpoint, and I was willing to take that vessel out from the very beginning. Whereas if I started in the main trunk of that Y, the reflux I saw would have gone somewhere I didn't want it to go. So I think that's a very good technique, and it allowed me to really learn how quickly to expect reflux and how to pay attention to that. So I would say that's a major step in learning how to use this product appropriately, is understanding how quickly it might reflux and how to recognize that.
What, if any, problems have you seen with injecting too quickly? I can imagine that is something that, you get in a hurry, maybe the adrenaline's flowing. Like, what does that look like? And what is, how does the lava behave when you're injecting too quickly?
So I think if you're injecting too quickly, it depends on the vessel that you're in. If you're in a very small vessel, let's say a small 2 millimeter vessel like you laid out before, and you inject it very quickly, it's going to fill that space quickly, reflux quickly, and go down to many more proximal vessels. So that's what I would worry about. If you're in a larger high flow vessel, you will be able to push this further than you may have intended for it to go. And the slow injection will allow it to stay a little bit closer to your catheter and create a bit more of a controlled plug. So I hate to give you a very weak "it depends" answer, but it does depend on where you are, the size of the vessel, and the amount of flow in that vessel.
It probably also depends on the solution, whether you have the 18 or the 34 viscosity.
Yeah, that's exactly right. And
Yeah.
so I want to reiterate this point because I think it's important that if I'm using the higher viscosity, it means that I'm very close to my target and there's really no reason to inject it quickly. I think where you might want to even think about that sometimes is when you're further away. So there's a sense that if I inject it just a little bit harder, will it bridge that gap a little bit more reliably? I think in many cases it does bridge that gap more reliably, but you just have to be aware of the potential for reflux.
This may be a question that is silly, but I felt the need to ask it because it occurred to me. Do sometimes you start out with the lower viscosity and then switch to the higher viscosity? Or once you've chosen a solution, it's that solution until the completion?
No, we mix it up a little bit.
Oh, okay.
So it really depends, right? It depends on what I'm trying to do. So if I wanted to run forward
Right.
and get into some distal vessels, I might use the lower viscosity formulation, have it do that work for me, like I mentioned. But once it comes back, and let's say I need another vial of product, well, now my needs for that product are different. Now I'm just filling space. There's no reason for me to have a lower viscosity formulation because I'm just trying to fill the rest of that, let's say GDA or something like that. So at that point, I would lean towards a more viscous formulation. So I definitely mix it up. I think that I would say is a bit more common in some of the larger applications. So let's say either portal vein embolization or endoleak embolization or even some venous disease for varices. There you might want to use something, that doesn't run away from you first and then just fill the space. So there's potential applications for mixing it up a little bit.
Have you guys started using it for portal vein embo?
We have a little bit, and we've been very happy with it, the degree of filling that you can get. Yep.
Okay. I was just curious. I ran into a friend at SAR and he was looking. I mean, a lot of people say glue works fantastic for portal vein embolization, but
It fills space very nicely.
okay.
So you get the sense that you're doing a nice complete job in any of those large vessel applications.